Hi everyone, my name is Kayla Mondich and I am the manager and educator here on Pediatrics, and I'm just going to talk about some pediatric education in regards to the emergency department. One of the first things I want to go over is IVs. To determine the correct catheter size for a child, it requires this assessment of the child's age, weight, and size of their veins. With our infants, you're going to be using the 24 gauge, which is the yellow one. For our toddlers, the school age, they can do anywhere from a 24 to usually a 22, which is the blue catheter. And then teenagers, 22 to 20 gauge, and most of our teenagers can tolerate a 20 gauge IV, and that will be the pink catheter. One of the biggest things that I get asked is, what is the KVO rate for a child? So the keep vein open rate for a 12-month-old or less or younger is actually 8 mLs an hour, and then anything greater than that would be the 12 mLs an hour that you would see with adults. Also, one of the biggest things on the IV pumps is there's actually a pediatric settings. There'll be, ER setting, medical setting, and the PEDS one actually sets ranges to make sure that kid is not going to get too much of a fluid. Essentially, if you were to put in the pediatric settings that this kid is 5 kilograms, if for some reason you set in that this kid's going to get 1,000 ml bolus, it will flag it, turn it red, and ask you, are you sure you want to do this? So it's really a safety issue, so we want to make sure if a kid is getting IV fluids, antibiotics, that you are putting it on the pediatric setting. And one of the nice things too about this is that it locks the IV pump so that the kids or families can't mess with it. And then anytime you want to unlock it, you just put in the word key, K-E-Y, and it'll unlock it for you. One of the biggest things too is we as pediatric nurses are very specific about how we tape our IVs, and there is a reason to our madness. We need to be able to visualize that IV site. With our little ones, those IV sites can go bad really fast. We need to be able to assess any redness, if it's hard or swollen, all signs that the IV is infiltrated. And so we don't want it to be covered with any gauze, co-band, we need to be able to assess that. So with that being said, one of the biggest things also is the tape. So with our little ones, their skin is very sensitive, and so we want to make sure that, you can use the clear tape, but a lot of the times what we like to do is use this tape first underneath, put this tape over it to make sure that it doesn't, come loose. Same with like the arm boards. We say that if the IV is in AC, we really want to use the arm boards. We actually carry 3 different sizes. We have our infant sizes here that we carry. We have the small ones as well as the large ones. And the biggest thing too is we want to make sure that when you're putting the arm board on, that it is covered with something and not on the plastic. The arm shouldn't be on the plastic. And so I have a little visualization here, this little baby doll here. So we have the arm board on here with the tape, and then the IV site here, it is not covered with anything. One of the biggest things too is that we know kids' first reaction is to pull the IV site, and that's why, people's first instinct is to cover the IV site so that they don't see it. So we actually have these stockinets up here on Pediatrics, and they're the only thing that is approved to cover the IV because we can easily pull it back to see it. And so they just go over the arm board. And then anytime you need to look at the IV, it's as simple as pulling this up to look at it. But please, please, please do not cover the IV site with more tape, with gauze, co-band. There's been multiple instances where, a kid's IV is fine in ER, but as soon as they come up to us, it's infiltrated. The other things too is saline locking our kids. Unless there is a doctor order, a pediatric doctor's order to saline lock our kid, we ask that you please don't. If you're giving an IV bolus, if you can do KVO after, that would be great for us up here. The next thing I'm going to go over is IM injections. I know that in ER you give those quite a bit. So determining the appropriate injection site, for kids is based on, age, muscle mass, medication volume, and the viscosity of the medication. So really, for our kids, the muscle that we usually put IMs in is usually the vastus lateralis. And then for the older kids, it would be the deltoid. And so I do have this little diagram here. So the vastus lateralis muscle here on the leg is the one we usually do for our kids. And then obviously the older kids and adults, we do the deltoid. Trying to find the appropriate syringe then, our needle size. Most of our little kids up here would use a 22 to 25 gauge needle, anywhere from 5/8 to 1 inch. And these are one of the examples here that we have. And then the max amount that you want to put into a muscle is also based on the size of the muscle. So a lot of the infants will not get more than 1 ml of medication into one muscle. If you get medication from ER and it's got 1.5 ml of medication in it, you're going to have to split it and give 2 shots. And then giving an IM injection, you can stretch the skin or pull it laterally at the injection site to achieve like a flattening position, or you can actually grab the muscle. Let's see if I can do this here. Grab the muscle and kind of bunch it. Okay, you're going to insert at a 90-degree angle. Once you get the needle in, you want to aspirate. If there's no blood, then you push the medication through. After the injection is given, you want to make sure you apply pressure with gauze. You don't want to use alcohol wipes because they can actually irritate the skin, and you don't want to massage the site. The next thing we could talk about is pediatric code blues. So unfortunately down in ER you guys will see more pediatric code blues than we will see up here. And so I will just briefly go over a couple differences that you'll see in a pediatric code blue versus an adult code blue. With peds, everything is weight-based. Medications, equipment size, and so in a code blue, when they come in, you're not going to have time to weigh this patient. And so that's where the Braslow tape comes into play here. And it is a color-coded, length-based tape measure. And the idea is when the kid comes in, your kid's going to be lying here. You're going to measure here from the red down to the feet. Wherever the foot stops, that is the size or the weight you're going to use. So here on this kid, it stopped at 4 kilograms. Here, then, it's going to give you all the information for seizure medications, hypoglycemia, overdose. It gives you ET tube insertion length, all based on this weight that you got using the tape. And then also that's when the Braslow cart that is color coordinated with this. So every single length here is color coordinated. You have your red, pink, purple, yellow, and the Braslow cart will actually have those colors on it so that you can have easy access to the right size equipment. All right, so moving on to respiratory issues. So a lot of the kids that we get up here are actually respiratory related illnesses. Pneumonia, RSV, croup, asthma. One of the biggest things to look for, obviously, is retractions, nasal flaring, head bobbing, color changes. Any of that usually leads to more respiratory distress. Medications that you'll be using, antibiotics, steroids, albuterol, racemic epi. One of the biggest things is to always listen to kids' lung sounds before you do a respiratory treatment, and then always reassess after, just to make sure that kid, did it help at all? Do they need another one before they come up? And then also with respiratory issues, a lot of nasal swabs, flu and RSV with the kiddos. And so with the nasal swab here, I actually have one here. You just want to make sure that you place it in until you hit some resistance. You want to swirl it around 2 or 3 times, and you want to hold it for at least 5 seconds. So if this is our kiddo here, put that in, swirl it around, 5 seconds, pull it out. Alright. And then for oxygen needs with our respiratory kids, a lot of the O2 sats to be above a certain range is really depending on the doctor's order. Next thing we're going to talk about is, urinary caths and our PD bags for our infants. So I'm going to talk about here the PD bag first. Let's see if I can find it. Here we go. So this is the PD bag. The biggest complication with this is the contamination. If you put this on a kid and they end up stooling, you're going to have to throw the bag away even if there's urine in it because it's contaminated and you'll have to put a new bag on. Also, getting it to stick. I will say that the area will need to be cleaned off and you will need to pat dry and you need to make sure it is 100% dry before placing this on. And also checking it. You need to check this every half hour. The sooner that you can get it off and get the urine down to lab, the better. Also, a lot of the times it'll spill in the diaper the longer it's left on there. And then also, if you just put this on, please check it before they come up to the peds unit. Cath UA. This is what the Cath UA kit looks like. I'm going to open it up here. Obviously it'll be sterile technique. What you have in here, you have your sterile gloves, you have the iodine wipes, swabs, and then this is what you use to catch the urine. It's all in one tube. You slip this off, put that in. When the urine comes in, what happens is that you take this out and then close it. And then it is all good to go in there. So with our auto syringe meds, we have our auto syringe pumps. So for any kid that is 3 months of age or 5 kilograms or less, when they get antibiotics, they're going to be using the auto syringe pump. They will not have them IV piggyback. We were in the future going to have new ones that actually have a drug library on them because right now these do not, and it is a safety issue. And so the tubing that you would use with this, it's green. This is the tubing that you would use, and this actually connects to the syringe. A syringe like this. And then after it's done, it needs to be flushed with 2 mLs of normal saline. Weights, if you are able to get an accurate weight, please do. For any child that is less, that's 12 months and less or younger, we don't want any weight with any clothes, shoes, or diapers on. And then I'm just going to briefly talk about lumbar punctures. We don't do a whole lot of them up on the floor. I think down in ED you guys will end up doing more than we do. One of the biggest things is just positioning. You want them to be in the lateral recumbent position, on the side here, almost like in a fetal position. They'll have their back exposed. You want to make sure that when you're doing that, you are not flexing the neck too much where you actually compromise the airway. So always have at least a biox on when you are doing the lumbar puncture and holding. And then one of the last things I'm going to talk about is NG tubes. I know you guys don't get a whole lot of infants very often that come into the ER where you have to put an NG tube down, but there have been a couple times where we've been called to come down and do it. I just thought it'd be a good chance to kind of go over some education for infants and NG tubes. So the position that you want the child in is supine position. And with our kiddos, with the babies, you're going to want to swaddle them. It's the easiest way to get it done. And we have an 8 French NG tube here. It is a very long NG tube. Very similar to adults. You're going to measure from the nose, tip of the nose, to the earlobe, all the way down here. So in the middle of the xiphoid process and the umbilicus is where that should be. Memorize that. You can mark it with a piece of tape. You can mark it with, have a marker that marks it there. One of the biggest things too with the kids is you can't tell them to swallow when you're putting down the NG tube or drink some water. And so that's when a binky or a pacifier comes into play. Having them suck on that while you're trying to get the NG tube down. Just like an adult, put it down to that spot that you had marked. As soon as that is marked in the right spot, I usually just cut a tachoderm in half and place that right here. And then just make sure that you are charting at what length you have it at. Choking occurs, coughing, patient starts turning blue, decreased oxygen sats, it is in the wrong spot, it is likely in the trachea and not in the esophagus. And so you would just remove the tube and attempt again. To make sure it is in the right spot, you're just going to auscultate over the stomach. You're going to put like 2 cc's of air into a syringe, listen, and then also pull back for gastric contents. If you see that, we always push the gastric contents back in after. Right now, we are trying to get our pH testing strips to be the gold standard of determining whether that NG tube is in the right spot, but it is currently not common practice, but it will be in the future. And then if you have any questions or concerns about a policy, you can always find our pediatric policies on the internet, on the Elkhart General page. If you have any other questions or concerns, you can always email me also. It's at kmondich@beaconhealthsystem.org. And thank you so much.